Everyone to episode 2, Sponges, Ivalon, and the Rise of Breast Implants. I'm Dr. Whitfield, the board-certified plastic surgeon, and we're going to discuss in this series as we lead up to fat transfers and where they are today in 2025. Just to summarize, the first episode we discussed biomaterials used for injection and specifically paraffin. Paraffin was used and discontinued basically in the causes of chronic inflammation and poor patient outcomes. Now we're moving into this next phase of sponges, and I read several papers about sponges, and it was interesting. Obviously, paraffin didn't work. Surgeons were looking for alternatives, and sponges had been used for various reasons as a synthetic implant. And after these failures of injections, this, set the stage for this. These materials, I read papers about them, and they were used in studies, and in certain situations, there was not a lot of reactivity or infection. So experimentally, this seems like a material that could be used, but let's, think about it. We go back to tolerance, which is recognition of self, as we explained in the first episode. Your own genetic material is the best, and then everything else is going to be reacted to by virtue of it being foreign and your immune system recognizing it. So historically, if we refer to this next phase as the introduction of these sponges, Ivalon is a polyvinyl alcohol sponge. Then there is a Etheron, which is a polyether sponge, a polystan, which is more of a tape that gets wound up into a ball. So we'll focus on the Ivalon. Historically, I was able to see the most about that, learn the most about that. And so we're going to go over to a screen here, look at a paper by Dr. Peters in the Canadian Journal of Plastic Surgery. And this paper it shows from a historical perspective how these devices were packaged and what they looked like. And then there's a before and not a before, but a long-term follow-up of a patient, and is a fair amount of tissue reaction, and it leads to scar tissue formation, capsular contracture, all the things, and ultimately that ends up like so many of these devices being a problem. But let's just look at this. So I'm going to add this to the video now. So if you look here, this is what the device came in this container. And then this is not an implanted device, but this was what was contained historically in that container. It had broken down over time. The sponge would be placed, and this was, as the paper I read, through an inframemory approach. And then this is a patient example here. And so this would be a contracted device. It looks very contracted and firm already, and there's a malposition of the tissues and the device, and then a scanning electron micrograph showing just the fibrous tissue only grew for a very limited amount into the sponge. So the original concept was to place the sponge, there would be ingrowth into the sponge, less problems with capsular contracture because of that. However, that did not happen. We shift into the era of the introduction of silicone gel implants, the first of which was placed by Dr. Cronin and Giroux in 1962 in Houston, Texas. And then they presented this work in a paper, and the paper was presented in Amsterdam in 1963 at a meeting. The introduction of this is really, so this is the first generation of implants. These were produced by Dow Corning, and their period of time really was from 1963 to 1972. They had a thick shell, and the gel itself was a silicone filler, and it was meant to have a more natural feel. So we've transitioned from initially paraffin injections that cause a really distinctive chronic inflammatory process leading to granuloma formation, extrusion, all these things, really disfiguring if surgery had to be performed, to a sponge, the Ivalon sponge, really, for all intents and purposes, created and had problems with capsular contracture, limited ingrowth of the tissues, of the fibrous tissues. We saw that picture in the article that Dr. Peters published about that. And then now we move into the first generation of silicone implants placed by Cronin and Giroux, developed by Dow Corning. And the first generation had thick wall and thick gel. And so we'll talk as we go through generations of implants, and it changes, but the thickness ranged from 0.075 millimeters to 0.75 millimeters. And the gel consisted of a low molecular weight, either 6,000 to 38,000 Daltons, which is silicone fluid. And so silicone, I always think of it, silicone can be basically liquid, or if you remember the space shuttle, the black part of the space shuttle nose was silicone. So it has this wide range that can, be as firm as that on the space shuttle, or as liquid, as syrup. That's how I kind of think about it. And dealing with these different vintages of implants over the time of my career, which is almost 30 years at this point, it has been very different. The issues that have arisen from implants are not, limited to, but include capsular contracture, a concept called gel bleed, rupture, infections, biofilm contamination, as we'll go into later, and there's breast implant associated cancers, more of which have been seen in the past decade. And much like paraffin failed, the introduction of Ivalon sponges was associated with a capsular contracture rate, which ultimately led to their discontinuation. Implants can be saline or silicone. They all have a silicone elastomer shell. They can be smooth or textured, shaped or round. Each of them, because they're foreign bodies, has their own implications. And because they're foreign, they're all going to react. They're all going to cause inflammation. To what degree that affects an individual is a very long and involved discussion. But summarize it this way. As we transitioned and I prep for the next episode in this series, we're going to discuss the evolution of early modern fat grafting and liposuction. So we've went through paraffin injections. We've went through liquid silicone injections. We've discussed Ivalon sponges, and other sponges used in the lead up to the placement of the first silicone gel implants by Cronin and Giroux in 1962. And then there's generations of implants. And rather than belabor that, we'll transition from implants into the era of modern fat grafting